Okay. So this one is over. The anatomy part, so Dudzik part, and the intro one. If I can get this slide to progress. Oh. Okay, so we're either two different states. We're either volume overloaded or we're volume depleted. Okay, and so if we're overloaded, things are going to be, we're going to have edema. There's going to be fluid on the lungs, so crackles, orthopnea, so a shortness of breath when somebody's lying flat. So they might say to you that they are propping up on a bunch of pillows and at night, because if not, they get short of breath. Also, if they suddenly wake up short of breath, that might be another indication of having too much volume. Volume depleted would be a decreased turgor, dry mouth, tacky secretions, they're dizzy. If they stand up, they feel like, from a seated position, they feel like lightheaded. They're not able to have any urine output or low urine output. It's not advancing. So a urine dipstick is where somebody literally takes the stick and dips it in the urine, and you get a result. And that can give you some indications if it's a UTI, or maybe if they have protein or blood in their urine. Looks like this. So he says to know the significance of a dipstick. So really it's like what it's being able to tell you. So it's, but like we're gonna like talk about some of this stuff anyways, later on as we go through these. So, but this is what it looks like. You don't really need to know what it looks like or how to like necessarily like read it as far as colors. That part's not a big deal. Okay. Osmolality and specific gravity. So specific gravity is on the dipstick. Osmolality is not. And so our osmolality is the measure of dissolved particles in the fluid. So it's, I think of it as more like that deals with sodium. So if my urine is really concentrated, it's going to have a lot of sodium in it, and it's going to be like more than likely, and it's going to be very osmolar. The other side of the spectrum, if there's tons of water in it, it's very diluted, it's going to have a less osmolality, and so we're not going to have a whole lot of sodium in the urine. So if it's less than 300, it's going to be a tubular dysfunction, so we can't concentrate the urine. And then if it's greater than 1300, it would be a UTI, or we've got really way concentrated urine. a quick way of looking at it is looking at the specific gravity. So looking at this question, if a person has high osmolality and high specific gravity, are they going to be volume depleted or volume overloaded? What do you guys think? Depleted? Yeah, right. It's going to be depleted. Oops. Okay. So if there's an abnormal dipstick, then it gets like reflex to microscopic, which just means it goes to the lab, they look at it, they spin it and look at it under the microscope. And they're going to be looking for cells, white blood cells, red blood cells, casts, as well as crystals. And so casts are going to be cylindrical structures that form in the lumen of the tube, and it's going to give us some information about that urine. So if the urine's not moving, if the urine is acidic, if there's a lot of concentration to the urine, it's going to favor this cast formation. So the thing about casts, it's kind of cool. It kind of like, think of it as if you put like putty, I guess, in a tube, and then you remove the and then it's pushed through the tube. It kind of just like forms that that shape of the tube. So that's why they're cylindrical. Crystals. This was like really important. He really loves crystals. So calcium oxalate crystals are going to be from two things. His favorite is from ethylene glycol ingestion, so antifreeze, and the other would be like from like kidney stones. Some people just have calcium oxalate in their urine, but ding, 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 know that calcium oxalate is associated with antifreeze ingestion. Okay, so this is showing you what some of the casts are, and it's important to know some of these. So, and like he'll go over them later on throughout the course. Granular casts are one of his favorites, and that's going to be associated with tubular nephritis, crystalluria, of course, ethylene glycol, know that. Uric acid could be another one. White blood cells, it could be due to a kidney infection, pyelonephritis, or interstitial nephritis. It's more associated with infections. Red blood cell casts are due to like kidney problems themselves, like a vascular problem, vasculitis, hypertension. So that's what you need to be thinking of if you see a red blood cell cast. Those are pretty much the important ones there. Okay. So calcium oxalate are these envelope-shaped crystals. They didn't have any pictures on there, so you don't have to like worry about what it actually looks like, but this is kind of like for your enjoyment. Yeah. Okay, so a white blood cell that is in the urine versus a cast. Let me see if I can like find a picture. I think it like will make totally more sense when you see. picture. Oh, and by the way, doctors don't even ever look at urines. The lab does. And so then you just trust them on what they see and hope it's right. I think. I mean, it should be right. Okay. All right, so here's going to be white blood cells in the urine. And this can be associated with like a bladder infection, a UTI is usually what it's associated with. A white blood cell cast right here, see it's this like tube. And since it's going to be like that tubular structure, you know that when you see a cast, it's going to be associated with the kidney itself, so pyelonephritis. You're not going to get a cast with just a plain old UTI. Does that make sense? Yeah. Yes, it's something in the tubular system. So it's not really normal to have cast. It usually indicates something bad. I mean, it's not normal to have any of this. Like your urine should be pretty much clear when you look at it under the microscope. However, like this one looks bad. We've got, these are some squamous cells. And then we've got some bacteria right here. And then these are all white blood cells. This would be a red blood cell because you can kind of see that concave shape. And when we get to it, there'll be like another picture. But this one's kind of small, but it's like, it kind of looks like the bacteria are eating the squamous cell. It's kind of fuzzy. That's a clue cell. So we'll get to clue cells, but that's just so you kind of know what it looks like. I think it makes more sense when you know, when you see it. All right. I think this is easier. So this is a way that okay, this is a way that like internal medicine doctors sometimes like to look at labs, but it's not that important. Like, he's not going to ask you to know that. Okay. So GFR and BUN creatinine are really important things to know. He's not going to really ask you the biochem behind it. He doesn't really care. He may not even remember it anymore, to be honest. So GFR is the filtration rate through the glomerulus. and it's going to vary by age and race. And so when you get a GFR back on a chemistry panel, it's going to say African American or non-African American, because that also affects the GFR. So normal level is going to be 90 to 120. You're not going to find many patients probably that have that GFR. They typically are lower and have some problems going on. BUN and creatinine, so it's our urea, blood urea and nitrogen. It's going to be the waste products, and they're going to be measured in the blood. And so that's also going to be in our chemistry panel. So the normal ratio or normal level is going to be between 0.06 and 1.2. And they're going to be inversely related. It's not a perfect measure of the kidney function, but it's close. And we're going to look a little bit more at that. So as you can see, the serum creatinine has got to go up pretty high before it makes a change in the GFR. So here we are at 120. It's having to go up, let's see, like at 60, we're approaching 2 for our creatinine. For it to go all the way to 15, our creatinine is going up pretty high. Is it small? Guys, I do not know what's going on. How do I get? Oops. Okay, we're just going to do it this way. I'm sorry I'm struggling today. Okay. All right. So here's some scenarios. So I would 100% know all of these scenarios. So this is like looking at the dipstick that I said that we would probably talk about. So if we have positive nitrites, we have leukocyte esterase, and then we have white blood cell cast. What we're looking at, so leukocyte esterase is going to be like the dipstick version of white blood cells in the urine. Nitrites, if they're released when E. coli releases them, and that's the most common type of, or it's the most common agent to cause UTIs. So if we have nitrites and we've got leukocytes in the urine, and then now we've got white blood cell cast, it's probably going to be pyelonephritis more than UTI. But. So if we've got 3 to 4 plus, by the way, like 4 plus is like pretty much as high as you can get. So it's going to be a lot. So 3 to 4 plus of blood with red blood cells that are different shapes, with crystals and flank pain is probably going to be a kidney stone in the ureter. So that stone is going to be scraping down that ureter and causing it to bleed. And they end up being like sort of odd shapes when you look at it under the microscope. And they may have some crystals. They're normal shape, sorry. Dysmorphic cells with blood, and then acanthocytes and red blood cell casts are going to be more associated with glomerular nephritis. So usually for a stone, they're going to have to say flank pain. And then if they're weird shapes of the red blood cells, it's going to be glomerular nephritis. If you've got a lot of protein and fat, oval fat bodies, it's going to be a nephrotic syndrome. And we'll go over the difference. I think that's actually next block. He didn't like go into it like too much. This block, I think he said it's important to know, but like, he didn't really test over it. So it's going to be nephrotic. So the way I sort of think about this, if I've got a kidney function that's really bad, so I've basically got like a really high creatinine, I've got low GFR, like my kidneys are failing. That's going to be a nephrotic syndrome. If I've got a problem with like inflammation of the glomeruli, and sort of, it's not exactly infection, but like associated more of inflammation, then that's going to be the itis, nephritis, like pyelonephritis. So that's going to have that inflammation. And then nephrotic, think of more, it's got the oval body, and it has to do with like the kidneys failing themselves. And you're going to see a ton of protein in there because our glomeruli are not able to filter out the protein. So they get through the urine. If you see blood on the dipstick, 2+ blood, but when looking under the microscope, there's no red blood cells, then it's going to be rhabdomyolysis. So what happens is the urine is going to be pretty dark. It's going to be basically like black. They call it tea-colored urine in the lab. And so it looks like it's going to have a ton of blood. And when you dip it, it's going to have blood. But what it looks like when the reagent that's on the dipstick is looking for blood products, and so it's going to be positive. But under the microscope, all of those red blood cells have hemolyzed and broken apart, so there's not going to be any red blood cell intact to be able to see on the microscope. And so he really likes that one. Here's our ethylene glycol. So he's not going to probably ask it in this way because the dipstick can vary, but basically calcium oxalate crystals, ethylene glycol. And then if you just see white blood cells and nitrites are negative, it's probably just not going to be E. coli. Okay, so that's all of his lecture. So not terrible, in my opinion. I don't know about you. Okay, so I know I've got some extra stuff that you don't need, but we'll just skip it. So you need to know the anatomy of where, like the blood supply, but more importantly, importantly, where the kidney stones lodge, because I think that's what she dinged in class. So back to anatomy. We've got our renal. We'll just skip to the next one. I think it's more important. This was important for us. The arcuate separates the medulla and the cortex. I don't think it maybe is important for you guys to know. But I would just look over this blood supply again. Here's the ureters. So you've got 3 constriction sites: the uretopelvic junction, the pelvic inlet, and the uretovesical junction. So the way I think about it is like coming out of the kidney, going into the bladder, and then when it passes right over the inlet. So not too bad. I would look over for this. I would look over like pictures of like cadaver pictures to make sure that I could identify ureters. Hint, hint, wink, wink. Okay, so that's everything because she did not cover this. So I'm going to switch to the next PowerPoint. I don't like them to get too long, so. All right. So we've got our filtered load, renal blood flow, excretion, secretion, and reabsorption. So all that stuff from physio, we're just remembering back again. So we've got our afferent arteriole and our efferent arteriole. And from our afferent, we go and it gets filtered and then it exits. And that's where we like sort of measure our GFR. And then what's left over is our efferent arteriole. And then exchange can take place. Okay. Here's just some definitions just to remind you. So I wouldn't really memorize like all these equations. I think they're important for physio, but I don't think it's too important now. But if the GFR decreases, our filtered load decreases. So to avoid that imbalance, you must alter the reabsorption or the secretion. The kidneys self-regulate 3 ways: autoregulation, adenosine, and the RAS system. So we've got autoregulation. It's going to be the ability to maintain a constant blood flow. And there's going to be pressure changes in the blood flow to help with this autoregulation. And the GFR remains constant. So a way of knowing this stuff. So this is what somebody taught me last year, and I thought it was kind of a cute way to learn this. So you've got 3 doors. You've got your afferent arterial door, you've got your efferent arterial door, and you've got your GFR door. So our front door is going to be our afferent, our back door is going to be our efferent, and our GFR door is going to be like the side door. So there's all these cool kids at this party, and if we open the front door wide open, we're going to let in a bunch of people to our party. Now, if we close the back door or keep it almost closed, then people are starting to want to exit, the only place they can exit is through our side door. So our GFR is going to be increased because there's going to be more people going out of the side door. If instead we open our front door, we'll keep it wide open. And this time we keep our back door wide open as well. Then there's going to be more people coming through the front door, out the back door, and there'll be less people exiting out of the side door. So our GFR is going to decrease. A different scenario, if we barely open our front door, but we keep our back door wide open, same thing. There's going to be less people being able to, first off, make it into the party, and then second off, they're all going to be leaving out the back door because it's wide open. So our GFR will be decreased. So you can kind of just like think of these scenarios and go through them, and that's a way of thinking about your GFR. All right, so we had talked about like different pressures. The RAS system and NSAIDs. So NSAIDs are, let's see, I think I might have a slide on that. Yeah, I think I do later on. So we'll talk about that in a few slides. Okay. Oops, I skipped a slide. The adenosine. So our macula densa is going to release adenosine in response to high sodium. Adenosine is going to constrict the afferent arteriole, acting on that A1AR receptor. So that's our front door. It's going to constrict our front door so less people can come into our party. So that means our GFR is going to decrease. The macula densa is also involved in the RAS system. If the sodium's low, it's going to tell the JG cells to release renin and lead to eventual release of angiotensin II. And it's going to constrict the efferent arteriole, but not really the afferent. So so we're going to be closing the back door, but our front door can remain open. So we're going to have lots of people coming into our party, but not as many people leaving out the back door. So they'll leave out the side door, and that's going to be an increase in GFR. And so that's the same process. So you can see it's wide here. And so not as much can exit this way, and we can have more that go out this side door. So our GFR increases. And here's just our macula densa cells to remember some histology, and our JG cells. A granular cell is a modified smooth muscle cell of the afferent arteriole, and it releases renin. I don't think that's too important. Base converting enzyme is made in the lungs. Like, they may ask like some weirdo question like that, so that's just something that you might take note of, just so you know. Okay, and renin, again, it's released by the JG cells, and it's going to be inversely related to blood pressure and the chloride in the tubular fluid. It's going to be stimulated by CAMP and inhibited by calcium link pathways. Okay, ADH and ANP. So our antidiuretic hormone is going to regulate volume and osmolarity. And then ANP, also BNP, is where it's going to dilate the afferent arteriole, and it opposes renin. So RAS wants to keep fluid in, ANP, BNP wants to dump fluid. And you'll see with patients with CHF, they're going to have really, really high BNPs because they're trying to dump that fluid. Their body's not being able to compensate. I think his tables are always good to look at and remember and memorize and kind of just go through them. So I would just go through this a few times to make sure that you know it, you know where the inhibitory parts are and where it's stimulated. Okay, so this is a patient maybe with CHF or maybe kidney failure, some problem which is making them swell. And so in EPC, they tell you to check for pitting edema. And so that's what this person is doing right here. And so it's probably going to have a little crevice that stays there for a while in those legs. So the amount of blood going through the bloodstream as it perfuses the tissues is the effective circulating volume. And you may hear him talk about third spacing. And so that's going to be fluid in the interstitial space. So the fluid is not going to be in the bloodstream. It's not going to be in the cells where we can actually use it. It's going to be sort of in between the tissues. And it's going to lead to edema. So in heart failure, there's not going to be good circulating volume. Instead, it's in this third space. Yeah, so the net effect of this is going to be renal vasoconstriction if we've got decreased circulating volume. But the GFR is not going to change too much. Renal blood flow, renal plasma flow are also auto-regulated, similar to GFR range. I think that's probably the most important there. As GFR is going to decrease, the level of our toxins, the things that we're trying to get out, creatinine and urea, well, I guess they're not toxic, but our waste products, they're going to increase, and it's going to be associated with impaired renal function. And so here's looking at this again. It takes a pretty high GFR or pretty high creatinine to change our GFR. It takes, our GFR has to get pretty low to get to a pretty high jump in creatinine. Here is some here's some reasons for a decreased GFR, and we're going to talk about pre-renal, renal, and post-renal in a little bit. But I don't think they're important for this slide. I don't think these are super important. I'm just going to skip them. I don't think he's going to get too deep into this, to be honest. I don't even remember that it was I don't think his questions were that bad, honestly. Fitz's. And he only has 2, so can't ask you too much. I mean, we had 3, so. Okay. Remember that water follows solutes or sodium. I usually think of sodium because that's usually the one that's discussed. But if there's going to be a great amount of solutes in something, water is going to rush into that down its concentration gradient. So you're not going to be able to pull more sodium or solutes than you have available at this loop of Henle. So thiazides work by blocking the NaCl symporter. What do thiazides do with calcium reabsorption? That's got the answer, but yeah, increase calcium. Yeah, good. Okay, here's his, I totally just skipped like a ton of slides somehow. Let me go back. Okay, there we are. Okay. Okay, so we've got ICF and ECF, and just like looking at this graph, and I would like review these again, but the blue is normal and the different patterns are the abnormal for like our patient. So if we have increased ICF, so in the cells, extracellular fluid is going to be in our vessels. It's outside our cells, then like in our blood. If they're both increased, our osmolality is increased, but our volume of both are decreased, what is going to happen to our osmolality? Oh, we already said that. Or I just said that. Oh, I'm sorry, wait. Let me think about this. I think I read this wrong. I did. I apologize. Our test patient is going to be in the blue, and our normal is going to be the two patterns. For some reason, it's because Quadri taught us, and he had it the opposite way, and has me all confused. So osmolarity is going to decrease, and our fluid volume is going to increase. And so what would we call this if we have low osmolarity, high volume, increased volume in both spaces? It's okay. It's hypoosmotic, so less volume, less osmolality. Volume expansion, because we're increasing our volume. So an example of this is SiADH, which we'll talk about. So here's these pictures again. You might throw like one of those on there and make you say like, if it's hyper osmolar, and then volume expansion or volume contraction. Okay, here's like another picture of the same thing that he's went over and over again. And here it is again, and here it is again. And here's his summary. I think his summaries are pretty good. So I just read over that and get the highlights. All right. Do you guys want to keep going, or do you want to quit? Do either. I think I can finish them, maybe. Acid base is a little rough, but I'll do my best if you guys want to keep going. Okay. Let me share my screen again. Okay, so to throw this out here. The majority of the test is going to be over acid base because you have it so many times. You've got a TBL over it, and then this has two lectures for acid base disorders, and then you've got electrolyte acid base review, like combination review lecture as well. So I think that there's like 12 to 15 questions of acid base. And I'll tell off on myself just for a second. And this is like the only test that I've ever sort of run out of time on. And I thought it would be like really smart to save all of the acid base questions till the very end. And I have like 15 minutes to do 15 questions, like all of renal, basically. But I did okay. And I'll tell you how I did okay. Acid base gets super complicated, but the way he asked the questions were like basically how you did it first year. And so if you look at the pH, you look at bicarb and carbon dioxide and know if it's sort of like up or down, and that'll give you your answer. And then also look at the question stem and see what they were there for. Like, are they diabetic? Are they in DKA? And that can help you and give you your answer as well. So that's what I did. So with like no time to spare, just so you know, like it can be done. So they're not as bad as it's gonna seem. So remember, bicarb is a base, and carbon dioxide is an acid, but when it's with water, basically just think of it as an acid. So if we've got high bicarb, it's going to be more basic. If we've got high CO2, we want to think more acidic. Your body's pH is is basically at 7.4, so between 7.35 and 7.45. If it is out of that range, it's going to start developing the acid-base disorder. The other thing that we need to think about, we said that if CO2 is high, then it's going to be acidic. Carbon dioxide is associated with the respiratory system. Bicarb is associated with the basically the kidneys, the metabolic system. If a person starts hyperventilating and they're blowing off CO2, then there's not going to be enough acid in the bloodstream because we're getting rid of all of our CO2. And so it's going to cause a respiratory alkalosis. If a person, let's say, takes a bunch of opiates and they're not breathing really well, or let's say that they have COPD and so their lungs, they're not able to get out air, then that's going to be more of a respiratory acidosis because we're retaining too much CO2 or hypoventilating. Okay, so bicarb, if we have a lot of bicarb, then that's going to be more alkalotic, and it's going to be a metabolic alkalosis, like if there's too much aldosterone, because there's going to be more bicarb released by your kidneys. If you excrete too much bicarb, then it's going to cause, and you get rid of it, it's going to cause a metabolic acidosis. So like our ethylene glycol example. Okay. So looking at the mechanism of our CO2 and bicarb, here's our little equation. You don't have to like memorize it or anything like that, but that's our buffering system. Also, proteins, phosphates, bones, electrolytes moving also helps with buffering. He says that you really need to know the difference between buffering and compensation. Then if there's, it's important to know that, like, well, when buffering is no longer going on, then we're going to switch to compensation, and you'll see what that means. And I mean, you probably already know what that means. Okay, I'm just gonna skip this. Okay, we talked about that. Really, you just need to like get to the question. Like, he doesn't care why this happened, to be honest. It's just knowing the stuff. Okay, so we've got a little bit, we've got a star. Bicarb is, reabsorption is dependent on carbonic anhydrase. And it's one of the many things that happens in the proximal tubule. Titratable acid excretion or bicarb regeneration is, which is urine acidification or urinary buffering, is that generation of new bicarb. So amiogenesis is the name for that. I would probably just know probably the name. And so the majority of NH3 production is utilized as the excretion of hydrogen ion and chloride as NH4Cl. Okay, so I stole this chart. It's a really good chart to look at to know how to do these equations. So basically, you first start out with the pH. So if we've got a lower pH, then it's going to be, we're going to have an acidemia. So now we have to figure out, is it respiratory or metabolic? If our carbon dioxide is high, then it's going to be a respiratory acidosis. If our bicarb is low, then it's going to be a metabolic acidosis. So from there, what we do is then with a metabolic acidosis, you're going to do this Winter's formula, which we'll talk about, and you're going to calculate an anion gap. And then if the anion gap is high, you're going to calculate a osmolar gap and a delta-delta, which we'll talk about. And if it's a respiratory acidosis, you're going to want to know what the ratio of the difference of the bicarb to normal bicarb, and look at the AA gradient. So don't worry, this is just like getting you ready. We'll go more into it. With the alkalosis, we're going to have a high pH, and if our CO2 is less than 40, we're going to have a respiratory alkalosis. If our bicarb is going to be greater than 26, we're going to have a metabolic alkalosis. And from there, we're going to look for hypercalcemia. And then for the alkalosis, respiratory alkalosis, we're going to look for our AA gradient. So this is a good way to like look at this chart and kind of move through some of these questions. I will tell you, something that hurt a bunch of students in my year was that they got a metabolic acidosis, and then they went through and they calculated the anion gap, and they calculated Winter's formula, and it was like all-time suckers. So what I did was I just figured out, okay, is metabolic acidosis yes or no? Or, I would, figure out which one it was, what the main problem was, and then say, okay, it's a metabolic acidosis. Is it compensated? Yes or no? Okay, yes, it's compensated. Then it would be a metabolic acidosis with respiratory compensation. So it was like sort of like first year doing the questions again. And I didn't have to do any math. So technically you're like supposed to do the gap. And so that's why the students were doing it. And okay, for example, there was a patient, I think, a question, it was like, there's a patient with, that's diabetic, their blood sugar was like 400. They were type 1 diabetic, their blood sugar is 400. And then it gives you like some labs basically. And it gives you the normal range too, just so you know. But it's like the answer choices were like metabolic acidosis with normal anion gap and respiratory compensation. And then there's metabolic acidosis with high anion gap with respiratory compensation. And then there was like 4 more. So like okay, so technically you should be calculating the gap. However, their blood sugar's high, they're acidotic, they probably, you'll learn the like different, types. So they're gonna have like high anion gap. So you didn't have to do the math. Yeah, we'll get into Winter's formula. Don't worry. I want to go over it with you because I think it's important, not for step 1. I think it's important for step 2 and just like knowing in life. I have found out now that I've taken boards and I've, lived 3 rotations in 1 week of another one. And I found out a lot of the things that you learn second year is not beneficial for step 1. Or level 1. It's probably more beneficial for level 2, step 2, and for clinicals. So that's just like a thing to keep in the back of your mind. But it's like good things to know. So if they do ask you a question, if you already know the answer, make sure you look good. So I would like learn this. I mean, and you want to do well on your test, of course. Okay. So we're going to start easy and then we're going to get harder. So we've got a low pH and high CO2 for our respiratory acidosis. So let's look at an example. So our pH is going to be 7.32 and our carbon dioxide is 60. So if we look at this, our pH is going to be less than our range of 7.35 to 7.45, so we know it's acidotic. Our carbon dioxide is going to be high. It's greater than 40. So we know that carbon dioxide deals with the respiratory system. So we're going to have a respiratory acidosis. If bicarb is also high, would it have caused the acidosis? No, because remember, bicarb is a base, so it's not going to make it that way. Could bicarb be low and CO2 be high? And the answer is no, unless you've got a mixed respiratory acidosis and metabolic acidosis, which probably will not happen on your test, but can happen in the real world. And the stuff I've been studying for my co-mats it could happen on there. So it's good to know for next year. I know you probably don't care at this point. I don't blame you. Okay, so respiratory acidosis compensation secondary disorder is when we're going to look at the compensation ratio. So we look at the higher end of normal, 40, and we're going to want to look at what the change in the bicarb is to a CO2 above 40. So we said that our bicarb was 60. I'm sorry, our CO2 was 60. I keep saying bicarb, I meant to say CO2. Our CO2 is 60, so that's going to be 20 over our 40. And so that is going to be, bicarb is going to be 2 milliequivalents per liter over the normal range. So that's going to be a 2 to 20 or a 1 to 10 ratio. So we look at our 1 to 10, it's going to be acute respiratory acidosis. So I promise though, he never asked any questions like that, but it's probably nice to know. You might need to know it for your TBL. I can't really remember that part. Okay, so we have a practice question. Our pH is 7.34 and our CO2 is going to be 60 and our bicarb is 30, and then in the corner we've got our normal ranges. So what is going to be our disorder? I'm tricky, I didn't put the answers right there. So we've got a vote for respiratory acidosis, and we've got one with metabolic compensation. We've got sort of 2 answers. Okay. So let's look at this. So our pH is low. It's less than 7.35, so we know it's acidotic. Good job. Our carbon dioxide is going to be high, so that's our respiratory one. So it's going to be a respiratory acidosis, correct? Our bicarb is 30, which is above the 22 to 26. So yes, our primary diagnosis is respiratory acidosis, but there is going to be compensation because our bicarb is out of our normal range. And so we've got high bicarb, so that's going to be creating also a metabolic alkalosis. So, correct. Good job. Okay, here's another one. What is our, yeah, it was the last one was a respiratory acidosis with metabolic compensation. What is this one? Yeah, good job. It's the same thing. It's a respiratory acidosis with metabolic compensation. So here's some causes of respiratory acidosis. Hypoventilation, so obstruction, lung disease, COPD, opiates, sedatives, weak respiratory muscles, so like Guillain-Barré, ALS, myasthenia gravis, stuff like that. those, so he might say like a patient's taking a bunch of opiates or sedatives, and you have to know what to do with that. So that can clue you in that it's a respiratory acidosis. So the 8A gradient is going to be the difference of oxygen between the alveoli and the arterial blood, and it's going to tell you the type, if the hypoventilation is intrinsic lung disease or if it's not. Metabolic acidosis is going to be where the pH is going to be low and then the bicarb is also low. So our example, pH is 7.33, so it's low. Our bicarb's 20, so it's going to be low. And so the patient's going to be acidotic and the bicarb's low. So the patient's going to have a metabolic acidosis. So low CO2s cannot cause acidosis. Okay, so compensation. A metabolic acidosis compensation or a secondary disorder is when we're going to use this Winter's formula. So we've got our PCO2, and then that is 1.5 times our bicarb plus 8 plus or minus 2. So it's going to give us a range because of the plus or minus. If it's lower than expected, it's going to be a respiratory alkalosis. If it's higher than expected, the patient's going to have a secondary respiratory acidosis. Okay, so here's an example. So we've got 7.33 is our pH, our CO2 is 28, and our bicarb is 20. So if we plug this into the formula, 1.5 times 20 plus 8 is going to be 38, and then plus or minus 2 is going to be a range of 36 to 34. So if our CO2, which is 28, is less than the range, which it is, it's less than 36 to 40, then there's going to be a secondary respiratory alkalosis. If the pH is 7.32 and our CO2 is 33 and our bicarb is 16, we know already we've got this metabolic acidosis, and we are looking here at the Winter's formula. So we've got 1.5 times 16, that's our bicarb, plus 8 is going to give us 32. If we plus 2 or subtract 2, we're going to have a range of 30 to 34. Let's look back at our CO2. It's 33. That's going to be in our range, so there's not going to be a secondary disorder. So here is question number 3. What is the disorder? Okay, so if we use Winter's formula, so first we look and see, okay, our pH is low. So we have acidosis. Our CO2 is low and our bicarb is low. So since our bicarb is low, that means it's an acidosis. So it's a metabolic acidosis. So now we're going to use the formula of Winter's formula. So if we take this formula, well, I thought I could copy and paste it. Guess not. Let's try again. There we go. Then we're going to take 1.5 times our bicarb, which is 14. So I should have had a calculator out. 1.5 times 14 plus 8. What do we get? $29. Okay, so plus 2 is going to be 31. Minus 2 is going to be 27. So 27 to 31, our, let's look again. Remember, if our CO2 is in range, we're okay. Is it in range? 23? No, that is less than 27, so we're going to have a secondary disorder. Does that make sense? Which would be a respiratory alkalosis. So this is the way that, like, you're supposed to do them, but when you run out of time on a test, I just did it the old-fashioned way of last year. Okay. After you've checked for the secondary disorder, you need to see if there's also a secondary metabolic disorder. And so you do that with the anion gap. So our anion gap is going to be our sodium minus chloride minus bicarb. It's measuring the main electrolytes and seeing what the change is compared from our sodium compared to our chloride and bicarb. If you don't lose chloride, you're going to have a normal gap. Okay. So let's see. No. Okay. It kind of gets a little confusing, but we can do this. So if our sodium, let's say, is 128, and our chloride is 98, and our bicarb is 20. Sodium minus our chloride is going to be 30. Then our bicarb is going to be 10. So the number is less than 12. So we're okay. We've got a normal gap. If let's move this to 140. So if our sodium is 140, sodium minus our chloride, that's going to be 42, minus 20 is going to be 12. So it's greater than, well, maybe I should have made it 141. So now we've got 13. So it's greater than 12, so we're going to have a high anion gap, and you need to do another step. And this step is called a delta-delta. So what you do is you take your anion gap, so we said it was 13. So anion gap, so 13 minus 12, which is the normal, remember, number greater than 12. So we're looking at the change, so that's why it's called delta-delta, so delta divided by delta. And that's going to be divided by 24, which is our average bicarb. And our bicarb in this situation is going to be 20. So it's going to be 1/4. So, or 0.25. So let's look at this. If it is less than -5, it's going to be a secondary normal anion gap. If it's -5 to 5, there's not going to be a secondary metabolic disorder. And then if it is 5 or more, it's going to be a secondary metabolic alkalosis. So low delta-delta is a secondary metabolic acidosis. So you can have a metabolic acidosis with a secondary metabolic acidosis. And then, or a secondary metabolic alkalosis if it is high. Does that make sense? It gets confusing. So I'm going to go back to this little chart. So here we are, we've got our metabolic acidosis. We use our Winter's formula. If our formula is going to be lower than expected, we're going to have a secondary respiratory acidosis, or I mean alkalosis, sorry. If it's higher than expected, we're going to have a secondary acidosis. So we do Winter's formula. Then we're going to do our blood anion gap, so sodium minus chloride minus bicarb. If it is less than 12, it's normal. If it's greater than 12, then it's a high anion gap, a HAGMA. That's what it's also called. Then we're going to do our delta-delta. So that's going to be the change in our anion gap over that change in our bicarb. If we have a normal gap, we're going to do a urine anion gap. Are you guys hanging on so far? I know this is like super hard. Okay. Anyone else? Good. Okay, let's do these practice questions. Okay, good. I'm glad you guys are doing. Do you need more time? Or do you want me to talk about it? Okay, got an answer. We'll see. Okay. So we're acidotic, 7.33. Our carbon dioxide is going to be within our range, normal, and our bicarb is low. So we've got a metabolic acidosis, like you guys said. So let's do Winter's formula. So we have 1.5 times our bicarb, which is 16, plus 8, plus or minus 2. Okay. So if I calculate that out, we've got 32 plus or minus 2. So that would be 30 to 34. Okay. So does our carbon dioxide go in that range? No. Okay. So it doesn't go in the range. So now we've got a secondary disorder. Okay. Now we need to look and see, and so it's our CO2 is going to be high. So that would lead us toward acidosis. So respiratory acidosis. Okay. So now we got to calculate our anion gap. So our anion gap is going to be our sodium, so 145, minus our chloride, 120, minus our bicarb of 16. So I've got 145 minus 120 is 25 minus 16 is going to be 9. Is 9 less than 12? Yes. So that means we have a NACMA, a normal anion gap, metabolic acidosis, and respiratory acidosis. So correct. Good job. So see how you can easily get bogged into these. They take like forever, but they weren't that hard on test. I think you might have had to calculate maybe a Winter's formula or a HAGMA or something like on the TBL, if I can remember. So the diagnosis is going to be a metabolic acidosis with a respiratory acidosis. And it's a normal anion gap metabolic acidosis with respiratory acidosis is the official definition, which would be nagma. So that is the answer. Okay. Oh, I didn't take the answer out. You guys can like work on this. You can like look through this one on your own since I messed up and put the answer. I thought I'd removed it. Whoops. Okay. So I'll skip it. Okay. So cause of metabolic acidosis. So one that I remembered that I think is the easiest way to remember it is the mud piles. And so we're causing chloride loss. And remember that because I'm pretty sure he might ask that. That in hagmas, we have chloride being lost. So methanol, so mud piles, methanol. Methanol, uremia, DKA, propylene glycol, iron tabs, L for lactic acidosis, which I think was important, ethylene glycol, and salicylates. So, and that's late in it, so lots of aspirin. And they'll have like stage 4 to 5 CKD. And we'll talk about staging. I think it's in this block later on. If not, it might be in the third block. But so pretty bad kidneys. Moderate kidneys, moderate badness is going to be normal anion gap or nagma. And so some ones that go along with this is hyperalimentation, which is given too much IV nutrition. And it's going to like shoot that chloride higher. Addison's disease, renal tubular acidosis, diarrhea, acetozolamide, spironolactone, and saline infusion. I do remember. Okay, for the TBL, I would remember this stuff because I'm pretty sure that there were like straight up questions that said patient was given a infusion of normal saline. What type of acid-base disorder did they have? And that's all it said. It didn't give you any, you didn't have to, oh, that's it. You didn't have to do any math on the TBL. Now I'm starting to remember this. But it was all, you might have had to do like if it's acidotic or alkalotic, but there was like no math. And it was just like, patient took methanol. What is their problem? So make sure you know these. And it also like speeds you up on the test too. So FYI. Okay. So you can narrow down causes of metabolic acidosis using the urine anion gap and the osmolar gap. So the urine gap, remember our blood anion gap was sodium minus chloride minus bicarb. But with urine, we use potassium. So sodium minus chloride plus potassium. If it's negative, then it's going to be diarrhea, type 2 renal tubular acidosis, which we get a part of a lecture on, or saline infusion. If it's normal for it to be negative. If positive, it's caused either by type 1 or type 4 renal tubular acidosis. Osmolar gap is usually because of toxic alcohols. So I would know that. Okay, this was really important. So DKA, as it's treated and it gets better, we're not losing as much chloride anymore. So it's going to evolve into a nagma. So DKA starting out is going to be high anion gap. And as we get treated, we're going to be shifting and giving them saline and getting their glucose down, and they're going to be switching to a normal anion gap. So remember that. So as it's treated, NAGMA, because he might just straight up ask you that. He probably will. And remember, with NAGMAs, you want to get a urine osmolar gap, and he might say, like, what test do you order? You get a NAGMA, what test do you order? Urine osmolar gap. And then high chloride fluids, salt water, saline, all of that can result in a NAGMA. So just know that. Know those facts. Those are like easy facts that you can get right on the test. Okay. Do you guys want to keep going, or is your brain full? And we can like pick up later. Because I know this is like a ton. Also, I'll throw this out here to help you with the acid base. I found like free Boards and Beyond videos, and it was like they went through 8 problems on like free, I can't remember, like free tube, something like that. And so anyways, they were really good, and they went through Winter's formula. They just went through more and more examples with like I'm doing. Okay. Yeah, I would say work on the acidosis, work on the metabolic stuff, and get really good at that. So then we can work on the respiratory. So when do you guys want to resume?